What to do after intubating the patient? It has been seen, every student finds the process of intubating the patient fascinating and full of enthusiasm, but most of them seem to forget the patient after intubating. In reality, the post-intubation period is the most crucial. In our part of the world, finding a bed in ICU is very hard, so it is imperative for every emergency physician to learn post-intubation care. We will divide our talk into the following headings. 1. Analgesia. 2. Sedation. 3. Take home. Analgesia. Usually during RSI, paralysis and amnesia are induced, but not much is done to reduce pain. Analgesia. Jetzener et al. In a 2012 study proved that endotracheal tubes are painful. They measured hemodynamic and respiratory variables during ET suctioning to reach this conclusion. Another study showed that if good analgesia is maintained during the period of mechanical ventilation, it may eliminate the need for prolonged sedation, which in turn reduces ICU stay. Opiates, for example IV morphine boluses, are best suited for this job, but we can take help from non-opiates such as PCM, lidocaine, and ketamine. The most commonly used drugs for the purpose of analgesia in a mechanically ventilated patient in emergency room are fentanyl, remifentanil, morphine, etc. Fentanyl and remifentanil, later, have the advantage of shorter half-life and are not affected by the patient's renal and hepatic status. Fentanyl is given as an infusion of 0.7-10 mcg per kilogram per hour, and remifentanil is first given as a loading dose of 1.5 mcg per kilogram, then 0.5-15 mcg per kilogram per hour as maintenance. Morphine and hydromorphone. Again, the latter has the advantage of a short half-life and no active metabolite accumulation. Morphine is given as 2 to 30 mg per hour and hydromorphone as 0.5 to 3 mg per hour. Ketamine. Subdissociative pain dose is lower than the infusion dose used for sedation, given at loading dose 0.1 to 0.5 mg per kilogram IV followed by 0.05 to 0.4 mg per kilogram per hour. Sedation. Even if you eliminate pain, sedation may still be needed for patient comfort, ventilator synchrony, decrease oxygen demand, and work of breathing, etc. Also, sedation in the immediate post-intubation period is very essential if long-acting paralytics like rocuronium and vecuronium were used during RSI. Initially, a deeper level of sedation may be required to control agitation and assist in ventilator tolerance and synchrony. Later can be titrated to light sedation as demanded, in accordance with the RASS scale. Because studies have shown the detrimental effects of prolonged deep sedation, so always aim to achieve light sedation, RASS 0 to -2, if clinically appropriate. Benzodiazepine versus non-benzodiazepine? Generally, non-benzodiazepine infusions like propofol and dexmedetomidine are preferred over benzodiazepine infusions like midazolam or lorazepam. Some studies have even shown that benzodiazepines are associated with longer mechanical ventilation days, longer time to titrate to light sedation, and higher rates of delirium. But still, benzodiazepines may consider more appropriate in cases like refractory seizures or alcohol withdrawal. Dexmedetomidine versus propofol? Dexmedetomidine is a centrally acting alpha-2 agonist, while propofol acts on GABA receptors. Even though dexmedetomidine is a favorite drug for sedating ICU patients as it provides light sedation without causing respiratory depression, it seems in ED settings propofol may be still favored over it, as dexmedetomidine needs a longer time to onset. There is frequently an inadequate level of sedation mandating the need for other agents, and the risk of development of hypotension and bradycardia. Even in ICU settings, RCTs comparing propofol to dexmedetomidine failed to demonstrate the difference in outcomes. Most notable are SPICE-3 and MENS-2 trials. In the SPICE-3 trial, 4,000 patients were randomized to receive dexmedetomidine as the primary sole sedation agent versus usual care, propofol or midazolam or both. No difference in 180-day mortality was found. Instead, 74% of patients in the dexmedetomidine arm required additional sedation, with propofol or midazolam or both, and dexmedetomidine patients were associated with high rates of bradycardia and hypotension. In the MENS 2 trial, 422 patients were randomized to receive sedation with dexmedetomidine or propofol, and all of them were having a diagnosis of sepsis. Again, no differences in any outcomes such as the number of days alive without delirium or coma, ventilator-free days, and death at 90 days was found. Ketamine? Theoretically speaking, this NMDA antagonist should provide analgesia as well as dissociative sedation and not interfere with the hemodynamics of the patient. But there is a lack of prospective RCTs evaluating its use as sedation in post-intubated patients in ICU settings, although retrospective studies provide some evidence. Mainly it is used as an adjunctive sedative, and its use can decrease requirements for opiates and other sedative medications. Take-home messages. Analgesic first, prior to sedation, approach is the best suited pharmacologic management in the post-intubation period. Additional sedation if needed, for example for ventilator synchrony, should be light, RASS 0 to -2, and the degree of sedation should be routinely assessed. We recommend considering fentanyl plus propofol or dexmedetomidine as the routine first options for the choice of analgosedation agents in the emergency department. Propofol may often be preferable in the emergency department due to its rapid onset, ease of titration, and reliable capacity for sedation.